In this next segment, we're now going to trace the ulnar nerve as it runs down through the entire upper extremity and see where the motor and sensory branches come off, the muscles they supply, the skin they supply, potential impingement sites that the nerve can be impinged, compressed, or stretched along the way, and subsequent sensory and motor deficits and signs and symptoms that go along with an ulnar nerve injury. So, first thing to realize is the ulnar nerve is going to run down the medial arm, posterior medial, to the axillary artery. When it gets about halfway down, it's going to go through the medial intermuscular septum, which divides the anterior and posterior compartments of the arm. So it's going to go posterior. So it's going to run posterior through the septum, and then it's going to go under the arcade of Struthers, which is a fibrous arch that goes from the septum to the medial triceps. And this is the first potential place of impingement, is in this arcade of Struthers. Now, if it's injured in the arm, everything distal to it is going to be affected. Everything proximal, motor and sensory, is going to be intact. But there is nothing proximal, motor and sensory, to the arm. Everything motor and sensory is in the forearm and in the hand. So potentially, all the muscles that I went over in the sensory earlier could be affected with an injury to the ulnar nerve in the arm. This is referred to as a high injury, high ulnar nerve injury when it's in the arm. So you could have weakness in wrist flexion and ulnar deviation from the flexor carpi ulnaris, weakness in being able to flex the medial two fingers from the medial half of the flexor digitorum profundus. So there's your 1.5 muscles here. You could have, in the hand, you could have weakness flexing, abducting, and opposing the little finger from the flexor digiti minimi, the abductor digiti minimi, and the opponent's digiti minimi. And then from the dorsal interossei, DAB, you could have problems abducting the fingers. The palmar interossei, PAD, difficulty adducting the fingers in this manner. The medial two lumbricals, so difficulty maintaining the lumbrical grip for these medial two fingers, which is flexing the metacarpophalangeal joint and extending the pip and dip joints here. And finally, difficulty adducting the thumb up like this. All those can potentially occur with a high ulnar nerve lesion where all the motor and sensory is affected. That's motor-wise. What about the sensory? Again, is going to be the medial 1.5 fingers and hand, both on the palmar side and the dorsal side, with a higher density of receptors in the pad, so more tingling, pins and needles are going to be more experienced in that area, numbness, than other parts of the hand potentially. But with a bad enough lesion, you can feel it everywhere along the medial hand and medial 1.5 fingers. So that's a high ulnar nerve lesion. Then the ulnar nerve is going to continue down the posterior medial arm, and then it's going to go posterior to the medial epicondyle, which is over in this area here. And that's another potential site of injury with medial epicondyle fractures. And then it's going to go through what's called the cubital tunnel, formed from the medial epicondyle, the olecranon, the cubital retinaculum, also known as Osborne's ligament, and the two heads of the flexor carpi ulnaris. That forms a tunnel that the nerve is going to pass through. It's fairly superficial here at the posterior to the medial epicondyle. If you tap on that area and the nerve is injured in the cubital tunnel, you could potentially get abnormal sensation shooting down into the medial 1.5 fingers and hand. That's called the Tinel sign. So that's assessing the integrity, or assigned to assess the integrity or where the nerve is impinged, and in this case it could be impinged in the cubital tunnel. How else can you injure it in the cubital tunnel? A common way is hyperflexion, repetitive flexion, along with a valgus load. So a valgus load would be a load toward the thumb. So if we pushed on the forearm toward the thumb side, it's putting tensile loading on the medial elbow. That's called the valgus load in this direction. Along with flexion, that actually stretches the nerve. So we see this sometimes in our overhead throwing athletes with overuse type problems, repetitive throwing, as you go into external rotation in the arm cocking phase, along with that valgus inflection, you could get abnormal tension and stretch of the ulnar nerve, resulting in ulnar neuritis. So that's an impingement in the cubital tunnel. Once you do a lot of hyperflexion, you actually flattens the cubital retinaculum, which decreases the volume of the tunnel. So that's an impingement site. Everything distal, like we said, is affected. So you have a high ulnar nerve lesion, either in the arm or the elbow. It's basically potentially could affect all motor and sensory function. Now, as we continue through the tunnel, as it leaves the tunnel, it can also be impinged between the two heads of the flexor carpi ulnaris. That forms a fibrous arch known as the arcade of Osborn. So it can be impinged there, or as it travels through the two heads of the flexor carpi ulnaris. Repetitive use, again, involving a lot of wrist motion and deviation. Overuse of that muscle can compress the ulnar nerve. So it's more of an overuse phenomenon. And that can compress it. As it continues through the two heads of the flexor carpi ulnaris, it's going to run between that muscle and the flexor digitorum profundus, innervating both of those muscles. And then it's going to continue about a third of the way down. In the middle third of the medial forearm, the palmar cutaneous branch comes off of it. So it's going to travel down superficial along the medial forearm, across the medial wrist, and its destination is the proximal medial hand, or the hyperthenar region. It's going to supply skin to this area right here. So if you have an injury, a lot of compression over the medial wrist or anywhere along its path, that could potentially cause abnormal sensation in this area right here from the palmar-cutaneous nerve. Then the median nerve is going to continue down. In the distal third, the dorsal cutaneous branch is going to come off, distal third of the forearm. And it's going to travel deep to the flexor carpi ulnaris, and then it's going to work its way around to the dorsal side. So it really doesn't go superficial like the palmar cutaneous does. So a lot of compression here is not going to affect it. It's oftentimes spared, the back of the hand. And then it's going to go to the dorsum, the medial, 1.5 fingers, and the hand on the dorsal surface. So that's what the dorsal cutaneous is going to supply. Then as it continues down, it's going to go through another tunnel. And this is called Guyon's tunnel, or more commonly called Guyon's canal, formed between the pisiform and the hammock and the pisohammock ligament on the roof, and then the floor of it is the flexor retinaculum, or the transverse carpal ligament. So this is important to know clinically that it does not go through the carpal tunnel because it goes above the flexor retinaculum. But it can be compressed in Guyon's canal. How so? Well, obviously if you have a fracture of the pisiform or the hook of the hammock, or a dislocation, that narrows the content, the volume in the tunnel, that can compress the nerve. Or if you have a ganglion cyst on the volar surface of the medial wrist. Not real common, but it can occur some, and that can compress the nerve. Or if you fall on an outstretched hand, sometimes the pressure there, or again, dislocating the pisiform or the hammock. Or another common one is riding a bicycle, so handlebar syndrome, where you have constant pressure on your bicycle on the medial wrist over a prolonged period of time. That can also compress the nerve. The ulnar artery also travels with the ulnar nerve through Guyon's canal. So you have an arterial thrombosis. That can also cause potential problems as well. So there's several things that could occur here that can cause both motor and sensory abnormalities. Now, sensory-wise, like we said, the dorsum of the hand is going to be spared in this because the dorsal cutaneous nerve doesn't go through this area. The palmar cutaneous nerve does. It can be affected, as well as the medial 1.5 fingers on the palmar side in here. Those can be affected with Guyon's canal syndrome, as it's called, or ulnar canal syndrome is another name for it. So then from there, the ulnar nerve is going to go ahead and continue traveling through the Guyon's canal, and then it's going to split into a deep branch and a superficial branch. The deep branch is a motor branch, and it's going to innervate all the intrinsic muscles except for the 2.5 muscles in the thenar region and the lateral two lumbricals. That's going to be innervated by the median nerve. And the superficial branch is primarily a sensory, but it does have a little bit of motor to the palmaris brevis muscle, which wrinkles the skin in the hyperthenar region, helps improve grip. But other than that, the superficial branch is primarily going to be sensory. So it's going to provide sensation to the distal medial palm and the medial 1.5 fingers here. So it's kind of all in this area here. Now let's go back to looking at some signs. We've talked about a high ulnar nerve lesion and what it can do. What about a low ulnar nerve lesion in here? Well, it's not going to affect the muscles in the forearm. The 1.5 muscles have already been innervated. So it's just going to really affect the intrinsics. So you could have weakness and deformity. Some of the weakness you can have is weakness moving the little finger, flexing, abducting, opposing from the three hyperthenar muscles. The ability to abduct and adduct the fingers like this from the dorsal and interossei. Dorsal interossei abducts, dab, the palmar interossei, pad, adducts. So abduct would be, and adduction would be the function of the dorsal and the palmar interossei. The lumbricals, the ability to flex the metacarpophalangeal and extend pip and dip. That could be affected, but only on the medial 2 fingers, and the ability to bring the thumb up into adduction like this. Now there's some other signs that you should be aware of when you have an ulnar nerve lesion, especially a low ulnar nerve lesion like this. One is claw hand. So if you have the person make a fist like this and tell them to extend the fingers, that's the function of the extensor digitorum, which is a radial nerve. It can certainly initiate it, but the more the fingers extend, it's best at extending the metacarpophalangeal joints. It's not as effective as extending the pip and dip, because the more the fingers extend, their ability to generate tension diminishes. So that's where the lumbricals, primarily, and to a lesser extent the interossei, help extend the pip and dip. But in the digits 4 and 5, the ring finger and the little finger, they potentially could be completely gone. So that's where you get this claw hand phenomenon, where you have them extend their fingers, and these two extend fine, but these two here actually end up clawing. So a little bit like you see here, kind of a claw hand of the 4th and the 5th. Now you get some hyperextension at the metacarpophalangeal joint. That can actually stretch the flexor digitorum profundus, which is still intact with a low ulnar nerve lesion, this medial half. And that can actually exacerbate the claw hand. So if you have them extend the fingers, the extensor is actually trying to, all the muscles in the posterior compartment are actually trying to extend the wrist a little bit as well. To stabilize that, you have some activity from the anterior muscles, including a little bit from the flexor digitorum profundus, potentially. So that tension can actually, as it pulls the dip down from the flexor digitorum profundus, can help exacerbate the claw hand. So again, without the lumbricals working, which do this, you get the opposite response, which is more of a claw hand, and they can kind of adapt to this too through muscle contractures as well. It can adapt to a little bit of a claw hand, or it can be assigned by having them extend the fingers. Other things that you might notice is atrophy of the first dorsal interossei, where this muscle here, which is very prominent, the first dorsal interossei, it can atrophy where there's a great concavity that's very apparent visually that you can see in here. And all the, between the metacarpals, you can see a dip, a concavity in here with severe atrophy. So those are some other signs you can see with ulnar nerve. Other things, if you have the client try to hold a piece of paper between the index finger and the thumb like this, and then you try to pull it out, normally the IP joint is not going to flex. You have the adductor pollicis and the first dorsal interossei that can push down very forcefully like this. But if it's weak, then to compensate, the IP joint will flex like this as you try to pull the the paper out. So that's called Froment sign. It's a sign for ulnar nerve pathology. So those are some different signs. Again, the ability to abduct the fingers and other things that we mentioned motor-wise, as well as the abnormal sensation. All those you potentially could observe with an ulnar nerve lesion. So that summarizes the structure, function, and pathology of the ulnar nerve.